We're going to go over chapter 41, which is the OB chapter. This is going to be broken up into several different presentations. This particular presentation is going to cover the case study, the assessment, and the pharmacology review for OB-specific medications. So let's start with the case study. You were dispatched to a residence for a woman in labor. Upon arrival, you're escorted to the patient by her husband, who is clearly excited. He tells you his wife's water broke about 3 hours ago and now she's having contractions. You find the patient lying on her left side in her bed. She's having regular contractions every 3 minutes, each one lasting approximately 45 seconds. So you're going to perform your primary assessment. What you find: your appearance: she's conscious, holding her lower back and panting. She's alert. Airway is patent. Respirations are increased with adequate depth, but non-labored. Makes sense, right? She's in pain, contractions, birth, all that fun stuff. And then circulation: radial pulses, rapid and strong, skin is pink and moist. So, at this point, do we really have any immediate life threats? I don't think so. Remember, childbirth is not an emergency. Normal childbirth is not an emergency. It happens, or else we wouldn't be here, right? Abnormal childbirth, however, can absolutely be an emergency. So with this, what specific questions do you want to ask at this point? Right? Think about that for a second. What are some things that we need to find out? And it's something else to think about too, is that you don't know how long you have to get all these questions in. So you really kind of want to pinpoint and ask maybe some of the most important ones first, because they may not be able to answer all of them in a timely manner, because you're going to have a lot of questions, right? So some of the ones that we want to think about, some of the first ones I'm going to ask: how many weeks pregnant are you, or when are you due? I'm terrible at estimating, like, from the date of last menstrual cycle, the estimated. Just tell me when you're due. If it's, what's today? If it's May 1st or something and they're due in August, I know we're super early. If it's May 1st and we're due May 20th, well, we're still early, but we're not in the scary range of early. Does that make sense? That's kind of how I approach that part of it. All right. Have you had a baby or been pregnant before this pregnancy? And my next follow-up is, if they have, what happened? Were there any complications? Because historically, if they've had problems before, they may have problems again. Or for instance, some women may have to have an emergency cesarean section, and so then they're told from then on out they have to have a C-section. Well, guess what? If I know they have been told they have to have a C-section, there is no point in us sitting at this house any longer. We need to get going, because we're going to have to go to the hospital, right? So there's some very important questions you can find out. I also like to ask at this point: have they seen a OB doc? Have they been receiving care? And do they have any expected complications with this pregnancy? I always like to say that as long as I know the rules of the game, I can play the game. It's kind of like that with the patients. If I know what to expect, even if it's something really wild, I can deal with it a little bit better. If they tell me that the baby's going to have a cleft palate, is it going to really change anything that I do? Maybe, maybe not, a little bit, but I'm a little more prepared for it if I know what's going to happen than like, oh, hey, surprise. You know what I mean? Some other things: has your water broken? If so, when? What did it look like? Any funky smells, any discolorations, anything like that? If it was kind of stained, like the meconium staining, then that tells you that that baby is in distress. So just some things you can kind of find out there. How far apart are the contractions, and how long does each one last? The contractions will get stronger and closer together the closer we are to actual labor. All right? We want to find out, are we in imminent delivery or not? So we want to find out, do you feel like you need to push or move your bowels? You really want to get as much information as you can here. All right, so the patient tells you that this is their second pregnancy and she has had no complications with this pregnancy. She has a healthy 5-year-old boy. She tells you further that she feels as if she needs to move her bowels. What does that mean? Yep, that's it. That means she's about this imminent delivery. She's about to have that baby. So we're going to get ready for delivery. All right, the closest appropriate medical facility is 25 minutes away. And there's probably going to be like a cow in the road or something, because that's the way the EMS gods seem to work around here. As you perform a physical exam on your patient, your partner obtains the vital signs. And those are: she's still alert, respirations are 26 a minute, adequate depth, pulse is 110, radial pulse strong and regular, skin is pink, warm, and moist, blood pressure is 104/64, and 98% on room air. Okay, so based on what they've told you, what do you expect to find during your physical exam, to include visualization of the vaginal area? Contractions regular, occurring every 3 minutes. They feel the urge to move the bowels. I'm expecting to see some crowning, or if not crowning, some early like perianal bulging. I'm expecting to see some signs from imminent delivery here. All right. Do you have time to transport this patient to the hospital? Nah, boss. You better get ready. This baby is probably not going to make it to the hospital. Alright, so your visual exam of the vaginal area reveals crowning of the head. Told you. After ensuring that you and your partner are wearing appropriate attire, which is never enough. There's never enough appropriate attire to deliver in the field. It's going to be messy. This is why this reason right here is why I take 2 sets of uniforms. I wear one set and I take another set of clothes to work every time I go to work. You open the sterile OB kit, position the patient, prepare for imminent delivery. Right, go ahead and get that partner to sit next to their wife. Let them hold the hands because they're going to squeeze. You don't want that hand squeezing your hand. It's going to hurt. Alright, reassessment. Still alert. Respirations 28 breaths. So our breaths have gone up a little bit. Are we concerned at this point? For me, I'm not concerned. She's in labor. That stuff looks like it hurts, right? So I'm really, at 28, there's still adequate depth. She's still 98% on room air. I'm not concerned about that rate at this point in time. I feel like that's probably normal for, active labor. Pulse rate 118. Same thing there. That is a little bit high, but she's in active labor. She's in pain. There's a whole lot of stuff happening. So to me, that's still within the normal range, whatever I would expect for active labor. All right, skin pink, warm, and moist. Blood pressure 114/68. Same there. That blood pressure is a little higher than the last pressure, but it's still within the realm of normal, and I'm not concerned about that blood pressure at this point in time. I think that fits with the pain and the active labor. Right? So as the baby's head delivers, you note the presence of a nuchal cord. Alright, so the next thing we need to do is tell them to stop pushing so we can fix this problem. Partner puts on some supplemental oxygenation. Alright, so what is a nuchal cord? Right, that's where that umbilical cord is wrapped around their neck. Now, most of the time it's going to be fairly loose, and you should go and try to gently figure out which way it's wrapped, and then gently slide the cord over the shoulder and the head, and try to unwrap it around the head. Okay, if you cannot do so, the delivery cannot continue until you cut the cord, because it will tighten down like a noose around that infant's neck, and it will obstruct airflow. So, and oxygen delivery to the newborn, it will kill the baby. Alright, so if you can't slip the cord over, then you need to clamp and cut it once. Be very, very careful with this because you're cutting very close to their neck. But we really want to make sure that we want to tell mama, do not push while, just tell her, it's not a big deal. We've got this handled, but I need you not to push, because if we push, it's going to tighten that cord down. So they don't need to push while we clamp and cut this cord. Alright, so after managing the nuchal cord, deliver the rest of the body. It's a boy. He is blue, but he begins spontaneously breathing within a few seconds, and the mom remains hemodynamically stable. So you vigorously dry the infant, correctly position and wipe away some bloody mucus from the mouth and nose, and start to assess them. Our respirations are rapid and irregular with adequate tidal volume. Pulse rates 130 beats per minute, strong and regular. The color has central and peripheral cyanosis. Okay. So, should the APGAR score be used to determine what the need for newborn resuscitation is? What do you think? Why or why not? Right? So, the thing is that there's enough there without having to go through a whole APGAR score to determine whether or not we need to do resuscitation. Newborn APGAR is not gotten until about 1 minute, about a minute after the delivery, which doesn't seem like a long time, but it is when you're doing all this stuff. And then the second one's not done until 5 minutes. Well, we don't wait a full minute to say if we need to resuscitate this newborn, all right? We've got enough there. They're blue and they've got irregular respiration, so we know that they might need just a little bit, right? Now, is central or peripheral cyanosis is a fairly normal thing. Like, cyanosis of the hands and feet in and of itself is not a super big concern. The fact that he has a little central cyanosis is concerning, but usually easily managed. That should improve rather quickly with this. Now, the heart rate. The heart rate is a little bit lower than we would like. We'd like it around 150, 160 ideally, but 130, I think it was 138, still good. It's above 100, so that in and of itself does not require immediate intervention. Okay, so with that all in mind, Is there any additional treatment required for this infant other than maintaining airway patent and airway patency and providing thermal management, keeping them warm? All right. So at this point, like I said, central cyanosis, the hands and the feet, pretty normal, not a big concern. Central cyanosis, with as the oxygenation and respirations improve, they should start to improve as well. So in this case, I would say that vigorous stimulation, make sure the airway is open, make sure they've got adequate oxygenation, and thermal management is probably going to be enough for this baby. Right, so they stabilize. Their color improves. Their central color improves. So after wrapping them snugly, you hand them to the father and the mother, and you note significant maternal vaginal bleeding, and note that the mother seems a little pale. So with postpartum hemorrhage, okay, we as a civilized country, a nation, are terrible at recognizing postpartum hemorrhage for some reason. So it's really important that you look for the small things. If they seem a little pale, if their heart rate stays up, it stays elevated, if they start having small changes in their blood pressure, these are all signs. Keep in mind, they've still got about 30% increased blood volume. So they're kind of like kids in the fact that they'll seem fine, and all of a sudden, bam, they just like fall off a cliff. They can hemorrhage and fall off that cliff very, very quickly. So we want to pay very close attention to any postpartum hemorrhage. Average blood loss during normal delivery is about 500 milliliters. So if you think of like that half-liter bag of saline, about that much blood, which is still a fair amount of blood. But if we have continued hemorrhage, and keep in mind, we also can't see what's happening on the inside as well. All right. So how would we treat this postpartum hemorrhage? Do we need to do a crystalloid fluid bolus? Like I said, up to about 500 milliliters of blood loss can be expected, and that's normal in an uncomplicated delivery. But this seems to be a little bit more. She's pale, that kind of stuff. So the first thing we want to try to do is have that infant nursed from the mom. This will stimulate the pituitary gland to secrete oxytocin, which is not only the feel-good hormone, but also it promotes uterine contractions. Because what happens is that uterus will start to contract, and then after they deliver the placenta, then it's basically like a big open wound in there. And so as that uterus contracts, it helps slow the bleeding from that, where the placenta kind of peeled off of the uterus, the uterine wall. And if it does not constrict and has that vasoconstriction, it'll keep bleeding. So that's no good. All right. So with this, sanitary pads over the vagina. You don't put gauze pads or anything else. You don't pack the vagina. Nothing goes in there. All right. If they continue, if the nipple stimulation from the nursing does not help with the bleeding and seeing some improvement there, after the placenta has delivered, you can do a fundal massage, a uterine massage through the lower abdomen. It's not going to be pleasant, but it can be done. Okay. If bleeding seems to be controlled and we don't see signs of shock, fluid bolus is probably not indicated. Set it to keep vein open, but monitor. If we do see that we are still having some bleeding issues, consider oxygen and shock management. Okay, so you allow the mother to breastfeed the infant, perform fundal massage. About 5 minutes, you see you feel the fundus firming up, and note the blood flow has decreased. So you prepare for transport, and you transport without any further complications. I'm going to throw another thing in here too. Go ahead and call for another unit. If you think you're about to have to deliver a baby, go ahead and call for another unit. Here's the thing. If you deliver and everything's good and nobody needs another ambulance, nobody is critical or having issues, you can cancel them. You can say, hey, never mind, we're good, thanks, appreciate you. If something goes wrong with either mom or the baby, you will absolutely need another provider to help. And yes, you have your partner, because you should not be driving down the road with this. You should be in place. But you can't transport 2 critical patients. And truth be told, you really should not transport 1 stable and 1 critical patient, because you can't adequately focus on both of them if something happens to one of them. So really, if you have a critical patient or a potentially critical patient, you should have another paramedic unit or another unit transporting one of them. All right, so on to the assessment. Lots of information that we've got to get here very, very rapidly. All right, and we've got very short amount of time to kind of get that patient to entrust us and give us the information that we need, so most people are kind of uncomfortable with this, but it's very important to be professional and have that confidence there. So we want to find out, of course, chief complaint. Just because they are pregnant does not always mean that the problem is pregnancy. So that's something to keep in mind as well. Good rule of thumb, y'all. Never assume somebody's pregnant. I'm just throwing that out there. Some folks are just fat. Some folks may have a tumor. Some folks may have ascites. There's a whole lot of stuff that can make a belly look big. Just, yeah. Alright, we'll get your sample history. Are they pregnant? How long are they been pregnant? How many times have they been pregnant? Get that GPA, that gravida, para, abortions. So how many times have they been pregnant? How many times have they had a live delivery? And how many times have they had miscarriage or abortion? And as far as that goes, it doesn't matter whether it was a medically induced abortion or a spontaneous miscarriage. They're kind of the same. Alright, and like I said, length of gestation, estimated due date. Something to keep in mind, first time mom, that labor is usually going to be a fair amount slower. Alright, we're talking like average 16 hours. So there's a good chance on the first time you may be able to make it to the hospital unless we wait a little long. Now, we want to find out if they've had any complications in a previous pregnancy or any other gynecological problems. Alright, have they ever had a cesarean section, a C-section? If so, are they planning a vaginal birth after a vaginal birth after a cesarean? Some doctors will allow that. A lot of times it will be depending on what type of C-section they had, whether they had a transverse or a my mind just went totally blank on the other one, a vertical one. But one of them, the vertical is more likely to have, I think it's the vertical. Anyways, one of them is more likely to have or more possible complication of a uterine rupture if they attempt that particular type of vaginal birth after that particular type of C-section. In other words, all that stuff I just said. If they've had this particular type of C-section, they're probably not going to do a vaginal birth afterwards because it increases their risk of uterine rupture, which is really super bad. Alright. Are they under a physician's care? Are they taking prenatal vitamins? Prenatal vitamins are super important for folic acid. Folic acid is required for neural tube development in utero, which causes all kinds of birth defects if that doesn't happen. When did they last see the doctor? Were there any complications? Did they have any concerns about the pregnancy? Any ultrasounds done recently? What were the findings? Any problems? Any abnormal presentations? Was there more than one fetus? Surprise, you got two in there. That's a surprise I want to know about. Any medications, over-the-counter, herbal, recreational drugs? If they're, if they did an 8-ball of Coke yesterday, okay, well that's not really cool, but guess what? Not my job to judge. So how it affects me and me delivering this baby? Baby more likely to be born addicted to drugs, so more complications, more likely to have some birthing issues. Mom is more likely to have like uterine rupture or hypertensive crisis. We don't want baby to breastfeed because cocaine can pass through the breast milk. So there's all kinds of things in there that kind of, these different medications, whether legal or illegal, can, the implications that it can have on your postpartum care as well as your delivery care. Maybe mom takes a specific type of medicine that doesn't pass through the placenta but may pass through the breast milk, and her doctor's advised her she doesn't need to breastfeed. So these are all kinds of things, we want to try to find out if we can. And then, of course, the good old standby, do they have any allergies? Is mom allergic to anything? All right, we want to try to get an overall impression of their health. If mom has a whole laundry list of health problems, then there's a chance that her birth might be a little bit more complicated. Okay, mom's overall young and healthy, then hopefully we won't have any issues. Any smoking, alcohol, or illicit drugs during pregnancy. This would be kind of tricky because people feel judged when you ask about this, because everybody knows you're not supposed to smoke, you're not supposed to drink, you're not supposed to do drugs during pregnancy, right? It's like a duh. So we've got to find this out and find it out without them feeling like they're judged, because if they feel like we're judging them, they're not going to tell us the truth. Okay? But we still need to know because it may affect how we handle things. Right? Do they have any current pain? If so, what's it feel like? How long has it been lasting? Where is it? Does it move? Is it gradual? Is it a sudden onset? When did it start? Does anything relieve it? Ever had this type of pain before? These are all these things that we're trying to find out here. Okay, we want to find out, is there any vaginal bleeding? Any spotting? If there is bleeding, how long did it last? What did it look like? What color was it? What were you doing when it started? Did you use sanitary pads or tampons to absorb the bleeding? If so, how many pads? Has the bleeding stopped? Were there any clots or the tissues? If there was and they have them, bring them with you to the hospital. Toss it in a red bag, bring it with you. Okay? Any other types of vaginal discharge? If so, what's the color? How much? How long has the discharge been happening? Any identifiable or weird odors? Some might say like disagreeable odors, things that are maybe not so pleasant. All right, these are all things that we got to try to figure out about this whole situation here. All right, now with emergency pharmacology, it's important to note that these physiological changes will have an impact to a degree on what choices, what therapies you have available, okay? So this is going to be specific to OBGYN and delivery type issues. But in general, keep in mind that IV medications can very quickly pass through the maternal cardiovascular system, so higher doses may be needed depending on what it is. Oral drugs can take longer to work because their GI system is slowed down because of the displacement of everything as that baby grows, especially in that last trimester. Some other things to keep in mind, your liver metabolism, your hepatic metabolism, your renal excretion has increased due to this increased blood flow. And remember, they're up to about 30% increased blood volume. So all of this causes those IV medications to pass through much more quickly. All right. Virtually every medication that we're going to give pre-hospital could potentially go through the placenta and affect the baby as well. Now, in some situations, it is what it is. For instance, you've got cardiac arrest, you've got to do the drugs. Because if mama dies, baby's going to die. All right? When it comes to actually medications for specific problems or things with pregnancy, it gets a little trickier. We don't have a lot of drugs that we use in the field for pregnancy-related problems. Right? One of those that we do use, however, is magnesium sulfate. And you probably recall it's used also for some respiratory issues. It can be used for cardiovascular issues. In pregnancy, it is used to manage eclampsia. All right, remember, eclampsia is that threshold basically where you've had that hypertensive crisis and now we're having seizures as well. So this steps in when the seizures happen. Magnesium is an electrolyte. It's in this case, it's going to act as a central nervous system depressant. Okay, it may occasionally be used in patients with preeclampsia to prevent seizures, but we're not going to do that pre-hospital. We're not going to treat for the eclampsia until it's full-blown in the seizure activity because it's very easy to cause complications for magnesium. Okay, so too much magnesium given too fast or too much can cause respiratory depression. It can cause hypotension, and it can cause full-on circulatory collapse. Okay, so it can be very dangerous. You have to give it slowly. If it's given rapidly, then your likelihood or your risk factor for this respiratory depression, for this hypotension and cardiovascular collapse goes up a lot. So this is why we're going to give it in a drip. We're going to give it as a slow IV push or drip for seizures. Okay? Now, you will see in books that it can be given as an intramuscular injection. If you were in a place that gives it, it's usually 4 milligrams or 4 grams, so you would be doing 2 grams. You're going to do it in 2 separate syringes in 2 different sites because it's a whole lot of volume. So you do like 2 grams in one arm, 2 grams in the other arm or hip or whatever. In most places, however, because of those potential side effects, you're going to give it as a slow IV drip or a slow push, which is going to turn into a fast drip. So, for instance, here we're going to do 4 grams and we're going to mix it in 250 milliliters of saline. We're going to administer that over about 15 to 20 minutes. Okay. So you may be like, why, if they're seasoned, why can't we just use Valium, right? Because why can't we use Valium or Versed or Ativan or something like that we would use normally? It crosses the placental barrier and can cause severe respiratory depression and problems with the newborn. Now, with that said, if mama is still seizing and you cannot control the seizing with the mag, and we're in status, then you may have to use that Versed or that Valium or that Ativan. But the magnesium, will help first, will help fix the problem. Now, let's say that you do the mag, and then sometimes things happen, and they do have that hypotension, they do have those issues. So now we have to do the antidote, okay? So calcium chloride or calcium gluconate, usually used for hypocalcemia, but it is an antidote to counter magnesium sulfate if respiratory depression develops. Side effects of this: nausea, vomiting, syncope, bradycardia, and dysrhythmias, and it can precipitate cardiac arrest. So we're talking super serious drug here. All right, it is an IV push drug if needed. Terbutaline. This one is a tocolytic, and it is a sympathetic agonist. Specifically, it is a beta-2 sympathetic agonist. So that means it is going to activate your beta-2s. In this case, we are working the beta receptors in the uterus, and it's going to help you be used, or it's going to be used in pregnancy to suppress preterm labor because it causes uterine relaxation. That uterus is not going to push out a baby if it's relaxed. It's the muscle spasms and tightening and contractions that cause the baby to be expelled. So by relaxing the uterus, hopefully the baby don't get pushed out. All right. It can also be used to treat pregnancy-induced asthma because, like I said, it works. It's a sympathetic agonist, so it's going to work on the beta-2s. It also works in the beta-2s in the lungs, so it's going to have a bronchodilatory effect as well, much like albuterol. All right. Side effects of this: hypertension, nausea, dizziness, chest pain, and cardiac dysrhythmias. So potentially pretty much the same ones as most of your sympathetic agonists already. All right, so Valium. We already kind of hit on this a little bit. It's a benzo. It's a sedative anticonvulsant. We do not use this initially in eclampsia because we don't want it to pass through the placenta. However, if the seizures do not respond to the magnesium sulfate, then we will have to look at something else, and so we might consider giving some Valium. And you're going to want to give the minimum amount possible to control the seizures so that we're not giving a whole lot to that baby. Okay. Side effects: nausea, vomiting, respiratory depression, hypotension, mama and baby. And then it also can cause maybe headache and have some amnesiac properties as well. Diphenhydramine. This is antihistamine. Okay, we use it to treat allergic reactions, but it has some sedative properties and some antiemetic properties as well. So hyperemesis gravidarum, and I probably messed up that last part, but we're going with it. That's where they just have extreme morning sickness, vomiting, and can often last throughout the pregnancy. So this is something that's considered to be historically safe to treat, that does not cause any having teratogenic properties, causing harm to the baby or anything like that. Side effects: drowsiness, headache, tachycardia, and hypotension. Amount here typically is going to be the same, 25 to 50 milligrams. And your last drug, specific to the OB stuff, is going to be oxytocin, also maybe called Pitocin. All right. Oxytocin is a naturally occurring hormone, and it causes uterine contractions, okay? So in the hospital, they use this to induce labor. We are obviously not going to be trying to induce labor. We are going to be using it in postpartum to help control any hemorrhage, okay? Side effects: nausea, vomiting, tachycardia, seizures, cardiac dysrhythmias. But this one is going to be a 10 units, and it's given an injection, IM injection, so like 10 units in the shoulder, one-time dose. Now you want to make sure that the placenta has been delivered before you give Pitocin, okay? Only used to control severe postpartum hemorrhaging after everything else has been done and all products from the uterus have been expelled. So in other words, the cord's been delivered, baby's out, placenta's out. You cannot give it before the placenta's out because it can cause premature detachment of the placenta and cause some significant hemorrhaging issues.